Welcome to OAC Health Talks. I'm Joe Naglowski, President and CEO of the Obesity Action Coalition, and we are excited for you to join us for this educational series that dives deeper into specific health topics that we know are important to you and the OAC community. Health Talks are designed to empower you while providing straightforward, practical answers and insights from trusted experts. So let's dive into today's topic.
Hello, I'm Dr. Stephen Dean. I'm a vascular medicine specialist and professor of internal medicine at The Ohio State University in the Division of Cardiovascular Medicine. I'm going to be talking to you or with you today on the relationship between obesity and lymphedema. So let's begin with what is lymphedema? Well, it's a chronic, typically, although not invariably, progressive condition caused by a failure of the lymphatic system to adequately receive and transport fluid back into the venous circulation. Excessive protein-rich fluid accumulates in the interstitial spaces, leading to leg swelling that looks just like this. Tissue changes, such as discoloration, hardness. If you were to feel that leg, it would be rock hard, and impaired immune function. So that's a good working definition. Now, there are three main functions of the lymphatic system that I would encourage you to commit to memory. Number one, lymphatic fluid removal. I think that's intuitive. Number two, immunity, especially local immunity. So patients with lymphedema have impaired local immunity, which predisposes them to developing soft tissue infection in their leg. This can be a recurrent lifelong problem. And then finally, the third function, which is often overlooked not only by patients but clinicians alike, and that is the lymphatic system is intimately involved in fat absorption and regulation. Remember that point throughout this talk. So what is the lymphatic system? Well, the lymphatic system is composed of a variety of vessels of varying sizes, or as small as small capillaries that you see here, to larger, more well-defined trunks that residing within the legs, the arms, the abdomen. And these vessels carry a clear fluid called lymph fluid. And this fluid is clear. It can be a little bit whitish and is composed predominantly of water, but also proteins as well, fats, very important point, and various waste product and cellular debris. And these vessels traverse 600 to 800 lymph nodes throughout the body. There's an example of the lymph nodes here within the pelvic region. And this is a wonderful representation here of a smaller lymphatic vessel termed a lymphangion. I want to point out you're going to see fluid within this vessel, and this vessel is surrounded by, you see all those, looks like bubbles? Those are fat cells. Just highlighting this intimate relationship between the lymphatic vessels and fat. And there's also a blood vessel you'll see right next to it as well. But here we go. Look at that lymph fluid. See the contraction there of that vessel? And then there's a blood vessel right there too. You can see the blood flowing through the vessel. But anyway, wonderful example of a smaller lymphatic vessel contracting. All right, and so this lymphatic fluid is transported through a series of progressively enlarging vessels. And these larger vessels are referred to as lymphatic trunks. And the largest lymphatic vessel in the body is termed the thoracic duct. And you can see here it runs in the midline within the chest as well as the abdomen. And all of the larger lymphatic trunks from the lower extremity actually empty into the thoracic duct. Now, the thoracic duct, let's follow this up, and you can see here that it ultimately empties into the vein underneath your left collarbone called the left subclavian vein. And note here the yellow color, and that's just showing the lymphatic flow in your body because it's one of two distributions. All the lymph flow from the left side of your head, your left chest, your left arm, and all of the flow from your lower extremities goes or is transported within this thoracic duct, which empties again into this left arm vein. Now, over on the right-hand side, you can see the right side of the face, the right chest wall, and the right arm. All of that flow empties into a similar right lymphatic duct, which empties into the vein underneath your clavicle termed the subclavian vein. So let's review the manifestations of lymphedema. Well, first and foremost would be even before patients necessarily develop swelling, just early on in their lymphedema, they'll often complain of a sensation of heaviness or tightness. Now, the cardinal manifestation of lymphedema would be swelling. Swelling within the legs, the feet, the toes, the arms, the hands, the fingers. And lymphedema is often manifested by associated aching or discomfort. Now, I'll point out here that most lymphedema is not particularly painful. If a patient comes in complaining of severe pain, I'm usually looking for some coexistent inflammatory component, maybe infection, but as a whole, lymphedema is not particularly painful. It can be associated with skin hardness and nodules, as seen here. Very prominent skin folds, very deep skin folds, as seen here. And this significant swelling, as well as the discomfort sometimes, can lead to difficulty with activities of daily living. So let's review the classification scheme of lymphedema, the associated causes. Lymphedema is classified as being either primary, meaning you were born with some type of inherited defect in your lymphatic system, or it could be secondary to some type of extrinsic damage. And let's review the causes of primary lymphedema. And these causes are broken down by age of onset of the appearance of limb swelling. This can be congenital, appearing before the age of 1, often present at birth. It can present between the ages of 1 and 35, and it's referred to as lymphedema precox. And then finally, there's a late onset lymphedema, a late onset primary lymphedema termed lymphedema tarda. Now, as far as these three presentations, by far the most common would be lymphedema precox. That is lymphedema appearing, although the range here says 1 to 35, these typically, or lymphedema precox typically presents in the teens, and it most commonly affects females as opposed to males. Now let's go on and review the secondary causes of lymphedema due to some type of extrinsic damage. Right there at the very top, you see chronic venous insufficiency. That's dysfunctional veins. There's an intimate relationship between the veins and the lymphatic system. When the veins don't work well, the lymphatic system becomes overloaded and damaged and doesn't work well. Filariasis or worm infections, that's more of a tropical problem such as Africa. It's not a big problem here at present. Recurrent infection, which can damage the lymphatics. Surgery involving the lymphatics, radiation therapy, advanced malignancy or tumor. And as you can imagine, these three factors you often see concurrently. And then finally, severe trauma to the limb can lead to secondary lymphedema. Now, what do you not see showing up here as a secondary cause of lymphedema? It's pretty important we talk about today's topic. Suspect you've guessed it, obesity. This was a 2008 reference. I think if you reference this today, hopefully you would see obesity listed as a cause of secondary lymphedema. So obesity and chronic venous insufficiency, that is dysfunctional veins, and lymphedema, these three disorders are inexorably linked in the form of a pathological triad, and you can end up with legs that look exactly like these. So obesity adversely affects the veins, it adversely affects the lymphatic system. In fact, I would submit to you that this pathological triad, which we refer to as obesity-associated phlebolymphedema, is the #1 cause of lymphedema in Western countries, especially the United States. You'll often see that cancer and its associated surgery is the #1 cause, but for those of us that treat lymphedema, and based on recent data, including data from my institution, we've clearly shown that it's obesity-associated phlebolymphedema is the predominant cause in the United States. So let's look at the stages of lymphedema. And this is in accordance with the International Society of Lymphology. You can see here there are 4 stages. We'll begin with stage 0, which is a subclinical or latent stage. Patients in this stage don't have any swelling, but they may have that sensation of aching and tiredness that I referenced earlier. Stage 1, mild, stage 2, moderate, and stage 3, severe. And I'm going to give you examples of all of these stages. Stage 1 lymphedema. This is mild lymphedema. It's usually pitting, which means when you put your finger or thumb on the limb, you can cause an indentation within the skin. The skin appears normal, as you see here, other than a Band-Aid. And the swelling is completely relieved with elevation overnight. So what about pitting? I just want to show you a good example of what pitting is. Note the thumb here indenting the upper part of that calf, and then when you release the thumb, you note that indentation, or that's a pit. So lymphedema can be pitting in early lymphedema, but when you get these advanced cases that have been complicated by these type of skin changes and hardness, the skin becomes non-pitting. You can't indent the skin. So let's move on and go to stage 2 or moderate lymphedema. Stage 2 lymphedema is lymphedema has been complicated by fibrofatty deposition. So the limb begins to develop scarring within the skin and the underlying tissues, as well as begins to manifest abundant local fat deposition. And because of the scarring, because of the fat deposition, now that limb starts to become relatively non-pitting. Skin changes appear, like I'm showing you here. Note the dried scaling skin. I'll give you another example of some skin changes. So not only do you see this dried scaling skin up at the upper portion of the calf, look at the appearance of the skin here. Looks like an orange peel. That's referred to as a podi-orange appearance. And you'll see that with your more advanced stages of lymphedema. And then finally, as opposed to stage 1 lymphedema, which is completely reversible overnight, now the swelling is incompletely relieved with elevation. And then finally, stage 3 or severe lymphedema. As you can imagine, this is associated with not only severe fibrosis or scarring of the skin and the underlying tissues, but these warty overgrowths, as you see here. Great example of what you can see in stage 3 lymphedema. And then finally, very abundant secondary fat deposition. And now this limb becomes completely non-pitting. And there's no appreciable relief with elevation overnight. So this relationship between lymphedema and obesity is highlighted in this 2022 article. I'm going to quote, and it's entitled here, "The Lymphatic Vascular System, Much More Than Just a Sewer." And a quote from this article is, "In stage 2 and stage 3 lymphedema, massive accumulation of adipose tissue is highly characteristic, and it gives rise to the statement, lymph actually makes you fat. It makes you fat locally, and it makes you fat centrally as well." And this is a wonderful post-mortem example of the fat deposition that complicates lymphedema. And this is an arm here on the right that is normal. This is an arm here on the left, from the same patient obviously, that has lymphedema. So you can see the swelling, but you also note all that yellow tissue there, that is fat deposition. And again, just 2 other examples of lymphedema. We've got an early stage 3 here and a stage 2 here on the right-hand side of your screen. And believe it or not, you might tend to think when you look at this that limb is predominantly composed of fluid. Up to 80% of that volume in the limb is due to local fat deposition, not fluid. And this is data from my institution at the Ohio State University Medical Center, where we looked at the clinical characteristics of lower extremity lymphedema in 440 patients. And we identified 4 subgroups of patients with lymphedema, including cancer-related lymphedema, chronic venous insufficiency-related lymphedema that we call phlebolymphodema, lipedema that had been complicated by lymphedema, we call that lipolymphedema, and then finally primary lymphedema. And I want to point out here, when you looked at these 440 patients, the mean or average BMI was 40. So that fulfills the definition of morbid obesity, also known as class 3 obesity. Even in the patients that had cancer-associated lymphedema, the mean BMI was 30, which still fulfills the definition of early or class 1 obesity, even in a cancer population. In our phlebolymphodema population, the mean BMI was 46, and the lipedema population was 48, and the primary lymphedema population, the mean BMI was 41. So in these 3 out of the 4 categories, these patients had morbid obesity, also known as class 3 obesity. Just so further highlighting this concept that lymphedema not only causes abundant local fat deposition within the limb, it causes central fat deposition as well. So more data from my institution at Ohio State, where we looked at the relationship between patients that had stage 3 or severe lymphedema with the following skin condition called lymphostatic varicosis, where you see these severe skin changes with associated nodules of varying sizes. And what we found is this patient population had a mean BMI of an astonishing 56. So just more evidence highlighting the relationship between extreme obesity and these extreme skin changes as seen here. And it's very rare that you'll ever encounter a patient that has these type of skin changes that is not morbidly obese or fulfill the definition of class 3 obesity. So what's going on here? You see this big mass on the inner thigh of this unfortunate patient. Let me give you another photograph of a similarly affected patient. Big mass on the inner thigh. What is this? Well, this is referred to, it's a subtype of lymphedema called massive localized lymphedema. These are also referred to as pseudotumors. And this extreme form of lymphedema, again, is a manifestation of extreme obesity. Here's one of the larger series looking at massive localized lymphedema, and you can see they refer to this as a quickly rising complication of the obesity epidemic. And in this series, the average weight was 407 pounds with an average BMI of 61. So like the skin changes that I referenced only occurring in patients with extreme obesity, this type of presentation, massive localized lymphedema, you typically only see it in your extreme cases of obesity. Incredibly disabling problem. So I've shown you a lot of pictures here of the physical findings of lymphedema. Let's look at the impact of lymphedema on the activities of daily living. It's one of total multifaceted suffering, no question about that. From a spiritual standpoint, patients will wonder, well, why did this happen to me? Not everyone gets this kind of problem. From a psychosocial standpoint, it's a painful reminder to the disease on a daily basis to look at their limb. As you can imagine, they have loss of body image. They have not only anxiety, but depression as well about what other people think about their swollen limbs. Getting appropriate clothes is problematic. Relationship with the spouse can be affected. We talked about the physical findings. I'm not going to go over that. But from a financial standpoint, work absenteeism, the cost of treatment, more so because it's going to be a lifelong problem in a lot of these patients. From a vocational standpoint, these patients may have to quit or change job if the job requires prolonged standing or skilled handwork if they have upper extremity lymphedema. And then finally, the impact on activities of daily living. A lot of these patients are not able to do everyday simple work like cooking, lifting even small weights like the pressure cooker or babies or the grandchildren. Unable to participate in sporting activities like jogging. Again, it can be total multifaceted suffering in a patient with obesity complicated by lymphedema. So here's an often asked question. So what occurs first? Is it obesity or is it lymphedema? And current evidence suggests that these two pathways are probably occurring concurrently a good portion of the time. It's a busy slide, but very important slide. This is a schematic of the mechanisms of obesity-related lymphedema. So we'll just start with obesity. So what happens when you have obesity? Well, you have an abundance of fat cells that are more numerous, fat cells that are larger than typical cells. And when you have a lot of fat cells, they begin to release a lot of inflammatory proteins known as adipokines. And when you have a lot of adipokines, it releases a lot of inflammation. So what happens when you have inflammation? Well, unfortunately, it ultimately can damage the lymphatic vessels. And what happens when you damage the lymphatic vessels? Well, they don't pump as well. And then they begin to leak. And when you can't pump the lymphatic fluid out and they begin to leak, you develop lymphedema. So what happens when you have lymphedema? Remember that slide, lymphedema makes you fat. It makes you locally fat. So now you stimulate more fat cell deposition. So you get this really virulent positive feedback loop, as you can see here, with these amplify each other. And then there are mechanical factors you have to keep in mind as well in patients that have especially extreme obesity. As you can imagine, these patients are not very mobile. So if they're not very mobile, they're not contracting their calf muscle on a regular basis, and contracting that calf muscle is incredibly important to transfer not only venous fluid but lymphatic fluid out of the limb. And then, as you can imagine, think of the limb I showed you that was scarred and had all the nodules in it. Do you think a patient that has a leg like that could effectively contract the muscle even if they could walk? Doesn't work very well. So just more lymphatic fluid accumulates in that scenario. And then finally, you have to consider the effect of pressure on lymphatic vessels from a big abdomen that looks like this. And when you have an abdomen that looks like this, it's hard to get lymphatic fluid out of the limb, and venous blood for that matter as well. And for the same reason, in patients that have massive localized lymphedema along the thigh, puts a lot of pressure on those lymphatic vessels, which causes more lymphedema, which causes more fat cell deposition. Here's a slide looking at the relationship between obesity and the risk of having associated lymphatic dysfunction. This is data from Boston, an often quoted study. And I'll just draw your attention to a patient population that had a BMI of 50 to 59. Over half of these patients, 63%, had lymphatic dysfunction when they were tested. And you can see here this percentage continues to go up until if you have a patient that has BMI of 80 or greater, 100% chance they're going to have dysfunctional lymphatics. So the higher the weight, the higher the risk of having associated lymphatic dysfunction. I think that's intuitive, but keep this table in mind. So BMI over 50, over 50% chance of having lymphatic dysfunction. So what are our management and treatment strategies for patients that have obesity with associated lymphedema? Well, elevating the limb, compression socks, compression wraps, Velcro wraps, lymphatic pumps that sequentially pump the fluid from the foot through the calf up to the thigh, and then all that fluid ideally gets transferred into the thoracic duct like I showed you, and it empties underneath the left clavicle. And then finally, manual lymphatic drainage that's performed by a certified lymphedema therapist. It's a very unique form of massage designed to mobilize fluid from the limb. And in patients that have enlarged abdomens with that pannus that I showed you, abdominal binders. Now, unfortunately, it can be extremely difficult to compress patients that have lymphedema in the setting of extreme obesity. And that's because of the associated lobules that you see here, the very deep skin folds, irregular limb shapes like you see here, often require custom-made garments that are fit by a custom fitter, which is usually this certified lymphedema therapist that I measured. You can't just go on Amazon and order compression socks for a limb that looks like this. They have to be custom fit and made by a medical company. It looks something like this. Now, even in an ideal situation where you're able to get a custom garment that fits that limb, it's very difficult for these patients to bend over and apply that stocking. It's very difficult for their caregivers to apply and remove that stocking as well. And then you have the need for frequent hygiene between these skin folds, which often become infected, often with yeast. Sometimes patients unfortunately soil themselves while urinating, for instance, and you have to take the compression garments off again. So then you have that challenge. So what has truly revolutionized compression for lymphedema, especially in patients that have significant clinical obesity, or the use of these Velcro wraps you can see here, much easier to apply and remove than a typical gradient compression stocking. But I don't want you to think it's entirely easy, because it's not easy, but it's certainly easier. And again, I think it's revolutionized compression in this patient population. So what about lymphedema and exercise? At one time it was thought that exercise could be deleterious and actually further damage the lymphatic system. That simply is not true. We have an abundance of evidence suggesting that's not the case. As far as exercises that work in the setting of lymphedema, they can be low intensity involving stretching and flexibility. That will stimulate the lymphatics. low intensity yoga exercise, exercise of moderate and high intensity by a certified personal trainer, and even weightlifting is recommended in the setting of lymphedema. I mean, you think of all the benefits of exercise. I mean, you stimulate lymphatic flow, you stimulate venous flow, you lose weight. It helps you from a psychological standpoint as well. So exercise is critically important in the setting of lymphedema. Probably wouldn't go this extreme though. Now, I am a huge proponent of water-based therapy, also known as aquatherapy, for lymphedema. I find this tremendously helpful in my lymphedema patients. They will tell you their legs feel so much lighter. It actually, due to the increased pressure, can mobilize lymphatic fluid. They get out of the pool, their limbs are less swollen, they feel better. And there's a good supportive database in the medical literature to support aquatherapy for lymphedema. This is a 2023 reference. So as far as lymphedema and weight loss, tremendously important, as weight loss can reduce the volume and the size of the limb. It can reduce the severity of their symptoms. How do you lose weight in the setting of lymphedema? Well, conventional measures, nothing unique here. Diet, exercise, medications, surgery. As far as what foods are recommended in the setting of lymphedema and obesity, here are the foods to consume on the left-hand side of your screen. Whole grains, healthy fats, omega-3 fatty acids, high-protein diets, diets that contain a lot of fruit and vegetables with the associated antioxidant properties. Note foods to avoid: sodium, refined sugars, refined flour. It's pretty stereotypical that when lymphedema patients follow a low carbohydrate diet, their legs don't swell as much. They feel better. When they go high carb, their legs swell more and their pain increases. Avoid processed food, pre-cooked foods, red meats, and alcohol is not helpful in the setting of lymphedema. And there are a plethora of very helpful books out there on utilizing a lymphocentric diet for patients that have obesity complicated by lymphedema. These are just 6 of the books that exist. There's a lot more out there. And as far as surgery, I mean, what do you do about individuals that are affected with massive localized lymphedema? Like, for instance, these can be excised, but that's problematic in the sense that you don't have many plastic surgeons out there that will do the surgery, and they're usually pretty restrictive when it comes to weight too. That is, they'll set a target rate for patients and say their BMI has to be less than 50, for instance, before they'll even operate. So for patients that have a difficult time losing weight, a lot of times this surgery is not really an option, which is unfortunate, because otherwise they just remain immobilized and their lymphedema worsens and they become even more immobilized, and their activities of daily living are increasingly impaired. There's a post-operative result. You can see your big scar there, but that patient was very, very happy to have that removed. There's another example of a procedure where they actually strip off all the fat. Don't see this done a lot. Actually, it's very uncommon, called the modified Charles procedure. All right, so we're going to conclude here with the following slide. Treatment of lymphedema in the setting of obesity clearly requires a multidisciplinary approach. It involves a clinician, and ideally it involves a certified lymphedema therapist. They have a tremendously important role in the setting of lymphedema with obesity. You may need a garment fitter in the remote chance that your certified lymphedema therapist doesn't fit the patient for their compression device. A dietitian, tremendously important for obvious reasons. Psychologist, because so many of these patients have associated anxiety and depression. Lymphedema support groups, these are tremendously helpful. And then finally, a social worker can be a lot of help as well. So I thank you for your attention on this very important topic of obesity that's been complicated by lymphedema. Thank you.